Hello students, it's Dr. Jami and we are going to cover our second last topic of biliary and gallbladder diseases. So our last topic is primary biliary cholangitis, also called as primary biliary cirrhosis. So let's make it some changes. So it's 3rd May 2024 and we are going to study primary biliary cirrhosis. So what is primary biliary cirrhosis? Primary biliary cirrhosis is a chronic progressive liver disease. Chronic progressive liver disease. Liver disease of autoimmune nature or origin, which is characterized by what happens in this disease, characterized by destruction of intralobular biliary ducts. So it's a chronic progressive liver disease of autoimmune nature characterized by destruction of intralobular bile ducts. So the epidemiology is same as you already know that the gallbladder and bile disease are more common in female as compared to male. So there is highly chance of females developing primary biliary cirrhosis or cholangitis as compared to men. In USA, usually it is 9:1. 9 women out of 10, 9 women develop having such autoimmune nature of disease, primary biliary cholangitis. So presenting age is 30 to 65 years. So it is the epidemiology. Now we are going to discuss what is the etiology. So etiology is going to be very important. So let's study. As I already told you that it is of autoimmune nature. So it is triggered by some environmental factors, and there will be a positive family history of primary biliary cholangitis (PBC). Positive family history. There will be positive family history associated with this disease. So there are other diseases which are associated with this PBC is are other autoimmune diseases like Crest syndrome. A patient of limited systemic sclerosis have Crest syndrome in which cutaneous and non-cutaneous manifestation take place. So other autoimmune diseases which are associated with primary biliary cirrhosis are Crest syndrome, systemic sclerosis, Sjogren syndrome, and Zika syndrome. So one autoimmune thyroid disease is also associated with primary biliary cirrhosis. So autoimmune thyroiditis, most common associated disease of autoimmune thyroiditis is which is associated with primary biliary cirrhosis is Hashimoto thyroiditis. Celiac disease is also associated with primary biliary cirrhosis. Or next autoimmune disease is rheumatoid arthritis. These diseases are associated with primary biliary cirrhosis. So, what is the pathophysiology? Now we are going to discuss is pathophysiology. I am going to make it quick and easy for you guys to understand. So there is a inflammation and progressive destruction. Inflammation and progressive destruction. These two mechanisms are taking place leading to intralobular bile duct destruction. So what will happen due to any autoimmune reaction of small or medium intrahepatic bile ducts, there will be progressive ductopenia. What will happen? There will be inflammation and progressive destruction of medium or small size intrahepatic bile ducts. When destruction take place, there is a regenerative mechanism in your body which tries to rebuild these ducts. So what will happen? There will be defective bile ducts. Body tries to body tries to regenerate these ducts. So there will be defective regeneration. The newly formed bile ducts will be defective. So what will happen? This leads to cholestasis, and it is a chronic condition, chronic cholestasis. So what will happen? This chronic cholestasis leads to damage of hepatocytes. So everything taking place in a chronic phase, chronic damage of hepatocytes. So what will happen when there will be chronic damage of hepatocytes which is secondary? Why it is called as secondary? Because it is due to production of toxins which usually, what will happen? So let's make it easy for you. When there is chronic cholestasis, there will be release of toxins. These toxins leads to secondary damage of hepatocytes. This, as stasis leads to more uh, time period, it will stays in our body. So toxins produced, and this stasis leads to damage of hepatocytes. This stasis and toxins leads to damage of hepatocytes. So what will happen? As toxins produced in our liver are present in bile or biliary fluid and released via GIT. So what will happen when there will be cholestasis? The toxins are produced in more quantity. These toxins and cholestasis leads to damage of hepatocytes which is secondary in nature. So what will happen? There will be gradual portal and periportal fibrotic change. So there comes a term fibrosis, fibrotic changes. So these fibrosis or fibrotic changes leads to liver failure. So liver's function is going to deteriorate. So when there is the condition liver failure and fibrotic change, it will eventually leads to liver cirrhosis. And we have studied that in liver cirrhosis, patient develops portal hypertension. When liver cirrhosis uh, becomes advanced, it leads to portal hypertension. So this is this is the pathophysiology you have to understand regarding primary biliary cholangitis or cirrhosis. There is inflammatory and progressive destruction of intrahepatic bile ducts. So what will happen? There will be progressive ductopenia. This progressive ductopenia leads to a regenerative phase in which there is defective regeneration of bile ducts. This defective regeneration leads to chronic cholestasis. So what is the function of bile? It releases it contains toxins produced in liver or present in liver. So to clear liver from toxins, bile is transported to GI tract. So what will happen when there will be cholestasis? These toxins are accumulated, leads to damage of hepatocytes, which is a secondary hepatocytic damage. So what will happen? There will be gradually portal and periportal fibrotic changes taking place in liver. So what will happen? Liver will started to fail in its function and synthetic properties. When liver is in liver failure state, it leads to fibrotic changes and liver cirrhosis take place, which eventually leads to portal hypertension. That is the pathophysiology of our primary biliary cirrhosis. Now we are going to discuss how a patient comes to us. What are the clinical features? Clinical features of primary biliary cirrhotic patient. So usually patient present to us with six clinical features. So initially the patient will be asymptomatic. Initially the patient will be asymptomatic. The body will try to overcome this situation on have without showing any symptom. So initially patient will be asymptomatic. The first clinical feature will be patient tells you that I feel over underpowered, I feel fatigue, and it is the first symptom usually develops in PBC patient. So a patient comes to you with and tells you that I feel low energy and feel fatigued all the time. And you ask about any other features, and he tells you that he also feels some itching in his body, usually called as marked pruritus. Marked pruritus, which is generalized in nature. So he tells you that he is having pruritus. So what will you think? You will think of primary biliary cirrhosis. So next patient will show some symptoms of cholestasis. Symptoms of cholestasis, as bile is not excreted due to defective biliary tracts or bile ducts. So symptom of cholestasis will also be present. So what are the symptoms? I already told you in choledocholithiasis and cholelithiasis topic that patient will have jaundice, yellow discoloration of skin due to hyperbilirubinemia. So what will happen next? Patient will have pale stools as bile is not entering in GI tract. So pale stools and dark urine. Next patient will have maldigestion as bile is not entering GI tract. Its function is to digest fatty foods. There is no digestion of fatty and non-fatty foods. So maldigestion is more common in advanced stages. So next is patient will have signs of cirrhosis. So my almost 2 hour lecture is out on cirrhosis topic, in which I cover everything about cirrhosis, and I explained portal hypertension too in that lecture. So patient will have signs of cirrhosis and portal hypertension. What are the signs of cirrhosis? And in early phases of cirrhosis there is a hepatomegaly. Then it leads to normal in size, then the liver shrinks and leads to liver carcinoma. So in primary biliary cirrhosis or cholangitis, there will be hepatomegaly with dull lower margin. There will be right upper quadrant discomfort. And what else you will find? You will find splenomegaly. So next clinical feature of primary biliary cirrhosis is hyperpigmentation. So what is leading to hyperpigmentation? It is darkening of skin due to presence of or overproduction of melanin. So skin will be hyperpigmented. So next clinical feature will be xanthomas. So what is xanthomas and xanthelasma? This is a condition in which cholesterol or fatty acid is going to deposit in your skin. So in xanthomas there is nodular, papular or planar lesions which is formed by the deposition of lipids in skin or subcutaneous tissues, or maybe in tendons too. So what is xanthelasmas? In xanthelasmas it is also a subtype of xanthomas which is characterized by lipid filled deposits which usually develops on medial aspect of eye. If accumulation of lipid on the medial aspect of eye is visible, you will label a patient as xanthelasma after lab studies. So this is all clinical features. Patient will come to you, first symptoms fatigue, then patient will develop marked pruritus, patient will have symptoms of cholestasis, patient will have hyperpigmentation, xanthomas and xanthelasmas, and patient will have sign of cirrhosis and portal hypertension. Fatigue, marked pruritus, sign of cirrhosis and signs of cirrhosis and portal signs of cholestasis, signs of cirrhosis and portal hypertension. Patient will have hyperpigmentation and xanthomas and xanthelasma. So how we are going to approach such patient for diagnosis? So first of all, you seen jaundice, you seen pruritus, you have seen portal hypertension signs, you seen dull right upper quadrant, or you asked about the history. Now you are going to do some lab tests. So what lab tests are usually done in such patient? Diagnostics. So we are going to study. So first thing is we are going to perform liver chemistry. We are going to check whether liver is function normally or not. So first thing is we are going to see that there is a cholestatic pattern of injury. Cholestatic pattern of injury. So what happens when there is cholestasis in your liver, cholestatic pattern of injury? So there will be, you perform liver chemistry and you will find rise in ALP whenever there is any abnormality in your liver and bile ducts. There will be marked elevation of ALP and GGT. So keep it in mind that if bile ducts, gallbladder and liver, these three things are involved, intrahepatic and extrahepatic bile ducts are involved, there will be raised in ALP and GGT. So what else will be raised? Direct bilirubin will be raised. So when we perform liver function test, there will be mild elevation of transaminases, mild elevation, or maybe it can also be normal. Transaminases will be mildly elevated or normal. So next thing we are going to perform, we are going to check liver synthetic function, as it also leads to liver failure. So we are going to check liver synthetic function is normal or not. So for this we are going to perform albumin test. The albumin will be reduced in primary biliary cirrhosis. There will be increase in INR in advanced stages. There will be increase in INR. So next we are going to perform CBC, as there is inflammation. So what we'll find? We will find thrombocytopenia in primary biliary cirrhosis. Thrombocytopenia. So in those patients where hypersplenism due to portal hypertension develops, it leads to thrombocytopenia. What is thrombocytopenia? There will be decreased number of thrombocytes. So usually patient comes to you with mucosal bleeding. So we perform thrombocyte count or we perform CBC. Next we are going to test lipid profile, as patient have developed xanthomas and xanthelasmas. So to check lipid profile, we will find hypercholesterolism. Patient cholesterol level will be raised. Cholesterolism. So more than 200 milligram per deciliter indicates hypercholesterolism. So next we are going to check antibodies, as it is a autoimmune disease. There will be production of some antibodies. So primary biliary cirrhosis specific antibodies are anti-mitochondrial antibodies. These will be present in more than 95% of patients. So next thing is, next antibodies will be ANA. ANA is anti-nuclear antibodies. These are those antibodies which directed against various nuclear antigens like DNA, RNA, histones and nuclear proteins. So if there will ANA will be present too. So next thing we are going to, these are auto antibodies. Next thing we are going to see immunoglobulins. Immunoglobulins. So these are non-specific findings. Auto antibodies are specific finding. So we are going to see which immunoglobulins will be raised. First one is IgM will be raised in PBC. Next thing is IgG will be raised in primary biliary cirrhosis. IgM will be raised and IgG will be raised. It is a less common finding, IgG raise. IgM is a common finding. So you have to remember this thing also. Next diagnostic thing we can perform for diagnosis is biopsy of liver. So most patients do not require liver biopsy to confirm primary biliary cirrhosis. And in order to so we take biopsy sample only to confirm either so in lab diagnosis or ultrasound scan or other things we seen uh, structure of liver and bile ducts. So, in order to confirm our suspected primary biliary cirrhosis, we perform biopsy. So, in order to evaluate any alternative disease present in or not, we perform biopsy. So, what will we find on biopsy of liver? We will find cholangitis and destruction of small and medium bile ducts. So what else we can do for diagnosis? We can do abdominal ultrasound. So if a patient comes to you, I already told you million of times that if a patient comes to you with right upper quadrant discomfort or pain, you have to perform abdominal ultrasound and you have to perform trans abdominal right upper quadrant ultrasound for gallbladder, CBD and pancreas, head of pancreas and duodenum, etc. So we perform abdominal ultrasound in primary biliary cirrhosis to rule out or to exclude either is there any mechanical bile obstruction or not, like choledocholitis is present or not, mechanical bile obstruction is present or not. So next diagnostic test we can perform is MRCP. We have to clear our differentials. We do not pinpoint, we cannot think pinpoint to primary biliary cirrhosis if a patient comes to you with these patients. So to evaluate if a patient having primary biliary cirrhosis or primary sclerosing cholangitis, we perform MRCP to evaluate for primary sclerosing cholangitis. So what is the pathology of disease? There are 4 stages of PBC. It is a fourth year medical topic you have studied, we are going to touch. So on histopathology it shows 4 staging. In stage 1 there will be lymphocyte infiltration, lymphocytic infiltration of portal areas. In stage 2 what will we find? We will find bile duct ductopenia, bile duct ductopenia. In stage 3, in stage 2 we'll also find there will be progressive cirrhosis development. There will be progressive cirrhosis. So in stage 3 there will be bridging fibrosis. You know what is bridging? There will be bridging fibrosis. In stage 4 we'll have finding of liver cirrhosis on histopathology. So these are the pathology of our primary biliary cirrhosis. So what is the differential diagnosis of PBC? So first is autoimmune hepatitis. Next is primary sclerosing cholangitis. Next we are going to discuss about is primary sclerosing cholangitis. So third differential is patient is having biliary obstruction or not. Biliary obstruction, like it can be either intraluminal or extraluminal. If there is any carcinoma of surrounding structure which is pressing bile duct, common bile duct and leads to cholestasis, there will be biliary obstruction symptoms. If there is intraluminal stone or CBD, common bile duct choledocholitis, there will be biliary obstruction. So any malignant or benign condition or intraluminal change or concretions can all lead to biliary obstruction. So next differential is our drug induced liver disease. Liver disease. So next differential diagnosis is sarcoidosis. So what is the treatment? So you have understand the pathology, pathophysiology, that there is inflammation and progressive destruction of intrahepatic bile ducts. What will happen? Let's draw liver. Intrahepatic bile ducts. So when there is destruction of these bile ducts, it's taking more time. What will happen? The bile produced here will not move to, let's draw our gallbladder. So there will be no bile production, as bile is not producing. So there will be no bile production or bile transport of, there will be no bile transport from liver to gallbladder and liver to common bile duct. So what will happen? There will be cholestasis, in there will be more bile in liver. So as you can see that bile is starting to deposit in liver. What will it leads to? It leads to destruction, or it leads to signs of cholestasis, and leads to destruction of liver anatomy, which leads to fibrotic change. So this fibrotic change leads to liver cirrhosis. So what will happen? So we have to produce bile, we have to give bile acid from outside. So the our general principle of management is we have to give ursodeoxycholic acid, ursodeoxycholic acid to all patients. So next I am going to tell you what is ursodeoxycholic acid. The next is we have to treat supportive care for the management of cholestasis associated pruritus. We have to treat pruritus. So next, our general principle of management is liver transplantation. Liver transplantation. So first we have to give all, first line treatment is we have to give all patient first line treatment ursodeoxycholic acid. What is ursodeoxycholic acid? You know that liver's function is to produce cholesterol. So cholesterol is degraded into byproducts which are cholic acid and chenodeoxycholic acid. So what will happen when we give ursodeoxycholic acid? It leads to, it is also, it is a bile acid. Remember it as bile acid, and not a toxic one. It is a not non-toxic bile acid. What is its function? Its function is to is anti-inflammatory action. It shows chlorotic action, like it moves bile, chlorotic, and cytoprotective effect. So ursodeoxycholic acid, it is a hydrophilic compound. Hydrophilic cholic compound. So what will happen? From cholesterol, cholic acid and chenodeoxycholic acids are produced as primary bile acids in the liver. So what will happen? These are secreted in bile into GIT. So what will happen in GIT? Cholic acid and chenodeoxycholic acid dehydroxylates are deoxylated. So after deoxylation, dehydroxylate, after primary, let's write it, dehydroxylated into secondary bile acids, which are lithocholic acid and deoxycholic acid and ursodeoxycholic acid, secondary bile acids by gut flora. So this ursodeoxycholic acid or deoxycholic acid or lithocholic acid, like secondary bile acids, are essential for the absorption of fats and fat soluble vitamins. So patient usually have malabsorption symptoms in primary biliary cirrhosis. So what it leads to? If we give first line treatment as ursodeoxycholic acid, patient disease will slowly progression of disease. So it also, when there will be slowly progression, there will be slowly development of cirrhosis or cirrhotic complications. So transplant period will be prolonged transplant requirement. So what is the second line option in pharmacotherapy in the treatment of primary biliary cirrhosis? First one is ursodeoxycholic acid. Next is obeticholic acid. So what is obeticholic acid? It is an farneside agonist of farneside X receptors. These X receptors are nuclear receptors that inhibits acid synthesis, bile acid synthesis. These farneside X receptors inhibit bile acid synthesis and intakes. So what will it leads to? It leads to decreased bile acid production in liver. So low bile acid, less cholestasis, and less cholestasis, less damage of liver and biliary ducts. So next second line option is we can give fibrates. So what are fibrates? Fibrates are lipid lowering agents used to treat dyslipidemia. So what complications can arise in a patient of primary biliary cirrhosis? So now we are going to study about complications which can arise. So first thing is that bile is not bile पहुंच नहीं रहा वहाँ पे GIT के अंदर. So patient will have malabsorption due to fat and fat soluble vitamin decrease absorption. Next thing, patient will have liver cirrhosis and portal hypertension. PBC leads to malabsorption, liver cirrhosis and portal hypertension. And next thing is patient develop osteoporosis. That's all. These are the most important complications of primary biliary cirrhosis or primary biliary cholangitis. That's everything about primary biliary cirrhosis. If you have any question, you can ask.